No multi-kinase inhibitors has been approved for use at this time. Many multi-kinase inhibitors were analyzed, demonstrating no efficacy in recurrent glioblastoma patients, such as sunitinib. It was analyzed in a single-arm phase 2 study in recurrent glioblastoma, gefitinib, an EGFR tyrosine kinase inhibitor, and it showed no efficacy in this setting of patients. Cediranib, it's a VEGFR2 tyrosine kinase inhibitor. It was analyzed alone or in association with lomustine in a randomized phase 3 study, and it failed to improve overall survival compared to lomustine in recurrent glioblastoma. Enzastarin, it's a serine threonine kinase inhibitor, and it failed to increase overall survival in this setting of patients. We know that despite surgery, radiation therapy, and alkylating agents, glioblastoma prognosis is still poor, and actually almost all glioblastoma patients relapsed. And there is no standard treatment for recurrent disease, and enrollment in clinical trials is recommended. But despite glioblastomas are highly vascular tumors with a high expression of pro-angiogenic factors, no efficacy in terms of overall survival for bevacizumab and anti-VEGF as first and second line treatment was demonstrated. Bevacizumab was approved in the USA by FDA based on uncontrolled data. And indeed, no survival benefit was demonstrated in first or second line treatment alone or in association with chemotherapy. Other options for recurrent disease can be temozolomide rechallenge or the use of nitrosourea treatment such as lomustine or temastine, a third generation of nitrosourea. The use of temozolomide rechallenge is based on a director trial by Weller and published on Clinical Cancer Research in 2015. In this study, patients with glioblastoma at first progression after receiving STUP treatment and at least 2 maintenance temozolomide cycles were randomized to receive temozolomide 1 week on, 1 week off. Primary endpoint was median time to treatment failure, but the results showed a similar outcome in both arms for median time to treatment failure and overall survival. Noteworthy, the median TTF in a patient with MGMT methylated tumor was higher compared to patient with a methylated MGMT. And so the conclusion of this study is that temozolomide rechallenge can be used in a glioblastoma patient with recurrence after a long time of interval between recurrence and the last temozolomide cycle. However, the activity and the efficacy of this schedule is limited. The combination of lomustine and bevacizumab was studied in IRTC trial, and it was published on New England Journal of Medicine in 2017 by Wick. And in the results of this study showed that the combination of lomustine and bevacizumab did not provide a survival advantage compared to lomustine alone. Indeed, the median overall survival was 9.1 months in the combination group and 8.6 months in the monotherapy group, with a hazard ratio of 0.95 and a p-value of 0.65. Tamiga trial, published on Oncologist in 2018, analyzed if maybe value continuing bevacizumab behind progression through multiple lines of therapy. The results showed that no survival benefit was observed with the use of bevacizumab from multiple lines in patients with glioblastoma progressed after a first-line treatment consisted of radiation therapy, temozolomide, and bevacizumab. In particular, regarding the second-line treatment, we had no difference of median overall survival between the combination arm and lomustine alone. And indeed, the median overall survival was 6.4 months versus 5.5 months in bevacizumab plus lomustine group and lomustine alone, respectively, with an hazard ratio of 1.04. Regoma is an important trial published this year on Lancet Oncology, and it was a randomized phase 2 trial comparing efficacy and safety of regorafenib, an oral multikinase inhibitor, versus standard treatment of lomustine in recurrent glioblastoma patients. The results show that overall survival was 7.4 months in regorafenib group and 5.6 months in the standard treatment. The hazard ratio was 0.5 and the p-value of 0.0009. Interestingly, the 12-month overall survival rate was twice higher in a patient treated with regorafenib, having about 40% versus 50% in regorafenib and the standard treatment, respectively. Moreover, also progression-free survival and disease control rate were increased in regorafenib arm. About safety, grade 3/4 treatment-related adverse events occurred in 56% of patients treated with regorafenib and about 40% in lomustine arm. However, most common grade 3 or 4 adverse events related to regorafenib were hand-foot skin reaction in 10% of patients, high increased lipase in other 10%, and blood bilirubin increased in other 10% of patients. But no death was considered by the investigators to be drug-related. Ponatinib is an interesting multi-tyrosine kinase inhibitor, and the preclinical studies demonstrated potent anti-tumorigenic properties in many types of cancers, including glioblastomas. A phase 2 trial was recently completed, and the results were presented at ASCO last year. And the results show that ponatinib was a well-tolerated treatment, but associated with a minimal activity in bevacizumab refractory glioblastoma patients with a 3-month progression-free survival rate of 0%. Other interesting ongoing trial analyzing kinase inhibitors are the association of lenvatinib, a multi-kinase inhibitor, plus pembrolizumab, an anti-PD-1, and it is a phase 2 study and just starting to recruit patients with recurrent glioblastoma. An ongoing phase 1 study is analyzing the safety of epitinib, a selective EGFR TKI, to treat glioblastoma patients with EGFR amplification. Checkpoint inhibitors are attractive treatments in the field of oncology. About brain tumors, nivolumab was analyzed in a phase 3 studies called Checkmate 143, and the results were presented at World Congress of Neuro-Oncology in 2017. It analyzed the efficacy and safety of nivolumab nivolumab in recurrent glioblastoma patients compared to bevacizumab, and the results show that nivolumab arm did not meet the primary endpoint of improved overall survival when compared with bevacizumab arm. However, about 7% of patients treated with nivolumab reported a longer response than bevacizumab, and so it will be important to know eventually predictors to correlate with nivolumab response. An interesting association analyzing the combination of two checkpoint inhibitors is the phase 2 study analyzing the association of atezolizumab, an anti-PD-L1, plus isatuximab, an anti-CD38. The enrollment is just completed, and we are waiting for the first results. Other very interesting drug is depatuxizumab mafadotin, also called ABT414 or depatux-hem. It was analyzed in a phase 2 randomized study in recurrent glioblastoma patient with EGFR amplification. And the results showed that the combination arm, temozolomide plus ABT414, could be improve the overall survival compared to temozolomide or lomustine arm. Vorinostat is a histone deacetylase inhibitor. It was analyzed in a phase 2 study in combination with bevacizumab in recurrent glioblastoma. The results showed that this combination did not improve progression-free survival or overall survival. Another phase 1-2 study analyzed the combination of vorinostat plus temozolomide and radiation therapy in newly diagnosed glioblastoma, but the results were negative in terms of overall survival. Lastly, CAR therapy. It's a promising treatment. About brain tumor, we had 2 case reports showing an interesting activity of this treatment in recurrent glioblastoma, and they were published on the New England Journal of Medicine in 2016. And however, now the treatment is still too expensive, and there are only 10 clinical trials open all over the world for glioblastoma patient. And so we are waiting for the first results of this promising treatment. Thank you for your attention.